Hi, everyone. Thank you for joining us for today's webinar. In a moment, as people are joining us, today's discussion moderator, George Herbert Jones, Distinguished Service Professor at Crown Family School of Social Work Policy and Practice, and also the Director of CHAS, Professor Jean Marsh, will offer brief opening remarks and an introduction of today's presenter, Assistant Professor of Industrial and Management Systems Engineering at Kuwait University, Abdullah Alibrahim. If you have any questions during the presentation, please type them in the Zoom Q&A pane, and then the chat function will open up post-presentation to also field questions from the moderator. A recording of this webinar will be available on CHAS's YouTube channel, which can be accessible by searching YouTube for the Center for Health Administration Studies. And Professor Marsh, again, will field and moderate questions post-lecture. And now Professor Jean Marsh will introduce today's presenter.
Good afternoon, everyone, and welcome to this week's Michael Davis Lecture. It's my very great pleasure to introduce our speaker, who is a visiting fellow at the Harvard Kennedy School of Government at the moment, but more significantly is a valued colleague on a NIDA-funded grant on health disparities that I am serving as co-PI with Dr. Eric Guerrero of REBCOR, who is running a research institute on NIDA health disparities in Los Angeles. So we're delighted to hear this talk. I've been eager to learn more about the work that Abdullah has been doing, and I will turn it over to him. Thanks for coming, Abdullah. Go ahead.
Thank you, Jean. Thank you for this introduction. I'm honored to be here, and I'm thoroughly excited just to give you an overview, walk you through the research that we've been doing as part of the research team you talked about. I'd like to look at the title and just emphasize on the where component, right? So this says, where do clients receive methadone treatment? Disparities in driving time, choice of facility, and treatment completion. A lot of time, this where element of care, despite the fact that care is local, right? And most times patients have to be somewhere to receive care. The where component is often overlooked in classical statistical analyses. And then it's especially the case in substance use disorder treatment systems. I'd also like to take this opportunity to give a quick shout out to the entire team without whom this work would not be possible. Professor Marsh, Hortensia Amaro, Yinfei, Tenny, and Eric. So let's set the stage for what we're trying to do here. I think it should come as no surprise that there is this insidious opioid epidemic going on. In the last year alone, more than 75,000 opioid-related deaths were happened in the United States, and that captures right around 75% of all substance use-related or substance overdose deaths in the United States. This happens despite the fact that we have an effective evidence-based treatment out there. This is in the form of medication-assisted treatment, and that makes access to treatment one of the largest public health objectives. The challenges we face in administering this treatment happens to be that the fact that we're still facing challenges in providing that treatment or access to treatment for those at-risk populations. We're talking about ethnic and racial minorities. The treatments that happen to be effective also require frequent visits to the treatment center, right? So we're looking at methadone, which is often prescribed to racial and ethnic minorities, would require daily visits over the course of treatment, and course of treatment can span anywhere between weeks, months, and not uncommon to span even multiple years, right? So one might start thinking about the relationship between commuting to receive that care and the outcomes that we can expect from receiving that methadone or medication-assisted treatment for substance or opioid use disorder. So we did a thorough literature review, and we found relatively outdated studies, the latest of which happened to be in 2003, that looks at the relationship between commuting to care and treatment outcomes. That was conducted on a sample of right around 1,500 clients receiving outpatient treatment, not necessarily unique to opioid care. And they found that traveling less than 1 mile to treatment is associated with a 50% increase in completing that treatment plan, compared to those who have to travel longer than 1 mile. So you can see it's a very sensitive and it's a very small distance to cover, and that was associated with a very substantial change in the odds of completing treatment. Clients who have to travel more than 4 miles were associated with having shorter length of stay or shorter duration of treatment. We also see that distance was associated with the likelihood of pursuing aftercare appointments. So the studies we found tend to be small, they tend to be outdated. We all know how the road traffic network keeps evolving, and traffic right now is not what it was over the last few decades. So this got us thinking about what kind of approach we can try to imagine to make use of larger data sets, right? So we went to administrative data from Los Angeles County. Los Angeles County happens to be one of the most populated and culturally diverse counties in the United States. So we have episode level administrative data for opioid use disorder treatments. Maybe we can use some of the modern geospatial solutions to allow us to augment the administrative data set with commuting and spatial attributes, and enable us to conduct those geographically aware analyses, right? So we're no longer looking at the administrative data in the classical sense. We're now adding this entirely new dimension of looking at the geographical components, spatial components of care relative to where the patient or the client resides and where they end up receiving care. So we build this approach on the LACPERS dataset. The LACPERS dataset stands for Los Angeles County Participant Reporting System. We have close to 20,000 outpatient methadone episodes, covering right around 12,000 unique clients from 32 unique facilities all over Los Angeles County for 8 years, ending in the fiscal year 2017. So it's a very rich data set. And for each one of those episodes, we have the client's age, gender, the zip code they reside in, their medical eligibility, their education level. So a lot of socioeconomic variables, as well as the facility that they receive care at, and then also episode level characteristics such as the treatment start date, discharge date, wait times, and all of that. So it's a very rich administrative data set. It was used for multiple publications. A lot of policy insights were uncovered using that data set. And we imagined using that data to explore even more geographically aware analyses, try to capture a commuting snapshot of what's happening in LA County to pursue methadone treatment, identify disparities, if any, between different subgroups in driving time to receive methadone, relate commuting time and treatment outcomes, essentially verify the findings of previous studies. And then we're also trying to touch upon an angle that hasn't been looked at in opioid treatment, which is factors or choices that clients make as to where they receive care relative to where they live. So we're trying to understand what drives this bypassing behavior, where an individual would choose to receive care not at the closest facility, but at a more distant one. So we have a wide range of questions we're trying to answer. And all of these are built on this foundation of geographically enabling an administrative data set to open up a whole host of opportunities to understand commuting landscapes across Los Angeles County and eventually answer policy questions at the national level. So we start by developing this scalable approach to obtain an estimate of the driving time involved in every episode. So we took all of these close to 20,000 episodes, and we used ArcGIS just to geolocate individual clients and their facilities. And then we used an API, which you can imagine this being some sort of data pipeline between the data set that we have and Google Maps, where data can flow. So the data set the administrative data set would push a few characteristics to Google Maps, and then Google Maps would return certain values to be included in our data set. And we're specifically excited to calculate the expected driving time for every episode. And that would be the expected driving time mindful of the actual road networks, predicted traffic, predicted delays. So this approach is a very modern approach compared to the studies that we found back from approximately 2 decades old studies with a smaller sample size. We're now looking at a way to mechanize this entire, automate the process of starting with administrative data and then getting all the relevant geospatial components to embed within that data set. So I'm at risk of boring you. I'm just going to give you an illustrative example of what that looks like in terms of preparing the data set. So what you're looking at is an illustrative observation from the Slackperts data. We have the episode ID, a client ID, we have the age of that client, the gender, and then a whole set of covariates for that episode. We're interested in looking at this client zip code. So in this illustrative, client lives in zip code 90017. So what we do is that we use our GIS or Geographical Information System software to obtain the precise population weighted centroid of that zip code. And then we obtain the coordinates of that centroid. We also look at the facility ID, which happens to be F32. That's a masked ID that we know what that corresponds to. And then we get the coordinates for that precise facility. And then we feed this data into that API that we just talked about through Google Maps. And we get the best guess driving time between the 2 coordinates for that specific observation. So we end up with an augmented data set that has a whole set of covariates specific to the estimated commuting experience for that episode, right? So in this case, we might be looking at 5.7 minutes. That's the best guess driving estimate between where the client resides, approximated to the centroid of the zip code that they reported living in, and the commuting distance that they had to cover to get to that methadone treatment. We also get pessimistic and optimistic driving times from Google, and that allows us, Google Maps allows us to get a sense of how bad traffic can be, right? And that's something that no studies ever looked at, the effects of traffic into access to methadone treatment. So we're illustrating a way to utilize those existing pipelines between our data sets and some innovative GIS solutions to expand administrative data and then run all different types of analyses. So that's where the data set that we end up analyzing, and we start by just understanding the different facets that we set out to explore. So we're going to start with that first one, where we'd like to understand what does commuting look like to methadone treatment in Los Angeles County. And to do that, we created a very basic estimate. It turns out in the 20,000 episodes that we analyzed, the average estimated driving time from where the client resides to treatment is 10.7 minutes, right? That's less than we expected, but once we compared this to published studies out there, it seems that in urban areas, driving time is relatively short to the closest facility. And we ended up mapping. So what you're seeing here is like a heat map of Los Angeles County with the methadone facilities, programs, or treatment centers shown in the red location icons. And then the darker the zip code, the longer clients originating from that zip code have to drive to care. And that's based on the data that we collected. So these are individuals that have initiated treatment, right? We're using the average data, the estimated driving time to highlight what that looks like. And then unsurprisingly, it seems that in central LA, central Los Angeles County, there's lighter blue colors indicating that there's shorter driving times to methadone treatment, whereas in the outskirts of Los Angeles County, we see darker zip codes. And that's because clients residing in these zip codes have to travel farther to receive care. Another observation to note is that we're approximately 46% of clients or the episodes that we studied had the estimated driving time that's longer than 10 minutes. And we've all seen how sensitive outcomes can be, outcomes including completing treatment and staying in treatment can be, how sensitive they are to driving time, right? So that's a very alarming finding that we came across, and it's the first time that we've been able to run a commuting snapshot on this large data set that gives us a systems level perspective on what's happening in terms of commuting to receive methadone treatment. We now are interested in finding disparities, if any, for different subgroups that reside in Los Angeles County. And to do that, if we take a classical scientific method, the key dependent variable we're interested in is the estimated driving time for every episode. And we're trying to see if that varies based on age, gender, socioeconomic status. And we're going to do that using maps, comparing different groups, and even build a generalized linear model. The findings here is that I'm not going to look at all the groups, but I think it's important to look at the finalized model. And what we find is that younger clients tend to drive longer to receive care. We also found that those clients that have completed high school also have to drive longer to receive care. And then male clients have to drive longer to receive care. What you're seeing here is a decline in average or expected driving time based on these covariates, right? And these are after adjusting for the possible effects. So we're not looking at raw group effects. Instead, we're looking at the effects or the associations between specific covariates and driving time while adjusting for the remainder of the covariates. So we ended up building a model, and what you're seeing here is just a summarized version to the left of the broader model that we also run counseling episodes that we're not interested in for this talk. It's just a robustness check in this case. But what you're seeing here is that in methadone treatment, distance to care is connected with education level, or how far they have to drive is connected to education level, and it's connected with gender, and it's also correlated with the age of that client, right? So what we start exploring next is how those different commuting experiences can relate to outcomes, right? And what we see here is that the outcome variable is now treatment completion, and that's the completion of the treatment plan. And the estimated driving time is no longer a dependent variable. Instead, we see it as a an independent variable. And we're trying to see whether or not there is an effect or an association between driving time to care and whether or not a client completes treatment. And we use generalized linear models, specifically a logistic regression model. And we find a very alarming dose response type of relationship where, compared to clients that have to drive less than 10 minutes to care, clients that drive 10 or more experience a reduction in the odds of completing treatment. And that reduction is an approximately 33 to 40% reduction in the probability of completing treatment, right? And what we see here is this dose response, as in the longer a client has to drive, the less likely they are to complete treatment, at least up to 30 minutes. And I think beyond 30 minutes, we have very few observations that we cannot conclusively make a statement about the relationship between driving time over 30 minutes and the odds of completing treatment. But it's a very important finding to note that a 10-minute difference in commuting time to methadone treatment is associated with a significant reduction, more than a third reduction in the probability of completing treatment, right? So that's at this scale, the results that we're finding have not been found before at this scale. So this has been published in studies, and it led us to think about a whole set of different questions that we're going to talk about now. But here is an observation, a report of the entire regression model that we built. So what you're seeing to the left here is essentially a summary of the orange bars that I'm circling here. It seems that other covariates are not as significant. Medical eligibility is associated with lower odds of completing treatment, but no other covariates besides traveling time or the commute estimated driving time is associated with a reduction in the odds of treatment. And that's a very concerning finding that we come across. So I think it's worth stopping at this point and just trying to synthesize all the findings that we made. So we found that nearly 50%, or to be precise, 46% of all episodes that we've analyzed are driving longer than 10 minutes to receive methadone treatment. And that's a number that's associated with a significant reduction in the odds of treatment completion. When we start looking at which groups experience longer driving time to treatment, we find that young individuals, males, and individuals that have completed high school tend to drive longer to receive care. This isn't what we've expected. We going into this, we knew that there were more facilities closer to at-risk populations. Young male and high school completing individuals might signal some type of choice, maybe that's being hinted at here, where individuals are choosing to receive care at a more distant facility for a number of different reasons, potentially, including stigma, social stigma, not being wanted to be recognized in a specific area, or looking for a more well-known facility. So all of these components is what led us into exploring the next facet. And then lastly, the key takeaway here is that we found that driving 10 minutes or longer to treatment is associated with a significant reduction in the probability of completing a methadone treatment plan. So these questions we were able to get or glean insights on just because of the fact that we were able to build this scalable approach of geographically enabling the administrative data set that we started with. And then we start looking at, it opened up a new set of questions where we're now looking at factors associated with bypassing the closest facility. I mean, if we go back, it could be that those individuals tend to be more selective, right? So they're not just going to the closest facility, they're driving longer because they're choosing to receive care at a facility that has more capacity to satisfy their needs. So that led us to the last facet that we'd like to explore. And for that, we had to come up with a way to operationalize this type of behavior. So what we do is that we built an algorithm that systematically goes through all these episodes that we had. And then if we look at this illustrative case, consider client X, they reside in the specific zip code and they received care at facility Y, which is 13 minutes away. What we do is that we go to that client zip code and we try to see if there is any other facility that was closer to that client at that time. And if there was, then we would count this episode as an episode that was bypassing the closest facility. So we'd give it an indicator variable of 1 for the bypass. We'd also measure the difference in estimated driving time between the closest facility and the facility at which they received care at. So in this case, the closest facility was 7 minutes away, but they ended up receiving care at a facility that's 13 minutes away. So the difference in time is 6 minutes, and we capture that in another variable that we call time beyond closest facility for this bypassing episode. So we synthesize those two variables by creating a new variable that we call this like bypass category. An individual can be not bypassing. They can be bypassing, but driving less than 5 minutes beyond the closest facility. They could be bypassing and driving 5 to 10 minutes beyond the closest facility. And they can be bypassing and driving 10 plus minutes. And we do that just to get a scale of the significance of bypass, right? So you can imagine an individual living in an area where they have access to 2 facilities. One is 5 minutes away, the other is 6 minutes away. That's not the bypass that we might be interested in because it's not significantly altering the commuting experience that this individual undergoes. Whereas an individual that has a facility that's 5 minutes away, but chooses to drive 15 minutes to care, then that's a bypass experience that we're interested in measuring, right? So we come up with the bypass categories, and that becomes our primary dependent variable that we're interested in. And then that categorizes bypass, whether or not an individual bypasses or not. And then if they bypass, how far are they bypassing the closest facility? This gives us a very elegant way of understanding what's happening or where is the client receiving care relative to where they live and whether or not they have choices that was closer and that they chose to receive care at a more distant facility. So in this instance, this client X received care at facility Y. They drove 13 minutes. There was a facility that's 7 minutes away. This episode would be recorded as a case of bypassing between 5 to 10 minutes. We use this bypass variable as the dependent variable, and we look at the same set of covariates just to see if there's anything we can pick up. The first analysis looks at just the sheer number of bypass, right? And it turns out close to 50% of episodes are not receiving care at the closest facility, right? The average bypassing distance or bypassing time beyond the closest facility is 5 minutes. So that's not an insignificant average level of bypass. We start looking at a more detailed assessment of bypass and those categorizations, forgive me. And we find that over time, the level of bypass does not change. One thing to note, though, is the more significant level of bypass, meaning bypassing 5 plus 10 minutes, 5 plus minutes beyond the closest facility, did rise, right? So if we start looking at 2010, the number of the percentage of clients bypassing 5 or more minutes beyond the closest facility was approximately 18%. Towards the end of the study period, that was closer to 26%, right? So you see the spanning out effect. Even though there's fluctuations, it seems that the total number of bypass remains the same. Or I should say total percentage of bypass remains the same, but the portion of longer bypass seems to be growing. That's why it's eating up a bigger chunk of all these bypass episodes. You see the percentage of bypassing that's shorter than 5 minutes shrunk from 32% down to 26%. We also map out those bypass rates onto a map. We're interested in seeing on which zip codes is there more bypass. And unsurprisingly, we see that in central LA, the highest level of bypass exists. And that's why you see a darker colored zip codes. This means that individuals living in this area, potentially because they have more options, they tend to be bypassing a lot, right? Because they might choose not to go to the closest facility. There's one that's 2 minutes farther, so they might drive to that. And you see that in these urban centers of Los Angeles County, we have the darkest zip codes. But once we change the picture, where we're now looking at how far they're bypassing, we see that in central LA, it's very light blue, meaning that how long they're driving beyond the closest facility is very low. And now in the outskirts of Los Angeles County, we see that there are higher or longer driving times beyond the closest facility when bypassing. So we're getting a sense of this tension that exists, that in central LA, where there are a lot of choices, in urban centers where there are a lot of choices of facilities, we see that a lot of bypass is happening, but we might not need to be concerned about that, because that's where choice is being manifested. But in more distant ones, maybe in the outskirts of Los Angeles County, these are smaller facilities, and individuals that reside in these zip codes are choosing to drive farther, maybe to a larger facility potentially. So we're speculating. This study, I should emphasize, is a very exploratory study. We're not trying to answer the why. We're just trying to identify the what in terms of where clients are receiving care. And I think there are a lot of insights that we're looking at just by the mere ability of mapping out commuting journeys for this administrative data set. We're able to create an interactive map where a user can glide over any specific zip code and identify what's happening. So we have Santa Monica here, for instance. We see that 30% of episodes are bypassing, and we're looking at 108 episodes, and the average time beyond the closest facility is 15 minutes, right? And you can see in the map that there aren't any closer facilities besides the one within the zip code. That's why if they choose not to go here, they're probably driving farther. So it's a very interactive map that individuals can go into and identify a specific zip code, the closest facility, and what's happening in terms of bypass for that particular zip code. We also note that bypass rates tend to increase with age. What we're seeing is that this is the bypass that's not the significant kind, right? So they're bypassing less than 5 minutes, and that's the portion that's growing, whereas the darker gray portions tend to be the same across age groups. So nothing to note here, besides the fact that older individuals tend to bypass and shorter distances or shorter commuting time. That's what we observe here. Once we start looking at different races and genders, we see that African American and Black clients have the largest bypass rates. That's as a raw number, but it's the bypass rate is highest of the least significant kind, which is bypassing less than 5 minutes. We also break this down by gender. So now every bar on the left-hand side chart is now broken down into 2 bars, one for males and one for females, just to see if there are any differences that exist within gender and the specific race. So what we see here is that Black males and Black females have different bypass rates. The difference is accounted for by the smallest category. We also note that among Latina and Latino population, there's also the same difference that we're observing here. We're just trying to identify across groups what's happening. Or is there anything we should make note of in terms of just the bypass rates and the bypass categories that exist? We were also interested in looking at the facility characteristics associated with the bypass, right? So what we just looked at are what we call like demand side, right? So these are clients and the demand attributes and whether or not they bypass. Now we're looking at the facility side, right? Facility characteristics such as the size of the facility, and we represent that by the volume of care, volume of methadone treatment that the facility delivers, and then the waiting time to start treatment. So this gives us a sense as to maybe clients are bypassing in pursuit of shorter waiting times. Maybe clients are bypassing in pursuit of larger facilities. So it gives us a different angle in terms of understanding what bypass is associated with. We're now looking at facilities rather than individual characteristics. What this suspiciously elegant graph shows us is that if we look at the different bypass categories, we see that the category where there is no bypass, it tends to happen the most for clients that have a larger facility next to them, right? So if a client resides in an area where the closest facility is a larger one, meaning it's above the median in terms of the volume of care they deliver, then it's very likely that we would see no bypass, right? Whereas for episodes where bypassing happens at 10 minutes beyond the closest facility, this tends to happen, at least half of the cases happen where the closest facility is characterized as one of the smaller ones or below the median in terms of the size or the number of episodes that they deliver, treatment episodes that they deliver. So this gives us a sense that it seems that clients are bypassing in favor of larger facilities, or I should say, bypassing the closer, smaller facilities that might be relative to where they reside. We also see that in this chart, we're looking at different genders, and we're also trying to identify the relationship between the closest facility and the facility they bypass to, and that's specific to bypassing patients. And we do that for the different bypassing categories. What we're looking at here is that if we're finding an upward slope, it means that clients are bypassing away from the closest facility to a more distant one, and an upward slope indicates that the more distant facility has a longer waiting time to initiate treatment, right? So what we'd like to see is a downward sloping line, meaning that clients are bypassing away from a facility that has a longer waiting time, and they're going to a facility that has a shorter waiting time. That's what we would expect, right? What we're seeing here is that, let's take, for instance, females that are bypassing between 5 and 10 minutes. The closer facilities tend to have shorter waiting times compared to the facilities that they're bypassing to, right? And that happens less so in Latina females, right? But more so in white and African-American females. The only downward slope that we were able to capture, or the most salient one, is in females that are bypassing 10 plus minutes. And these are white females who we have suggestive evidence for is that they're favoring facilities that have shorter waiting times, right? So the closer facilities have longer waiting times, and they're bypassing them in favor of facilities that have a shorter waiting time. We also get another hint at that for males, specifically white and Latino males. Very similar trend, although not as strong or not as salient. It's also not statistically significant, the difference between the closest facility and the facility they end up bypassing to. But the key takeaway here is that, at least for Black individuals, male and female, they're bypassing in a fashion that's inefficient, meaning that they're going to a facility and they're having to wait longer to receive care, when there is a facility that's both closer and has a shorter waiting time, meaning they can initiate treatment sooner, right? So there's an efficiency angle that we're interested in here, that the data is signaling towards. There's still a lot to unpack within that data, but if we were to try to look at the key takeaways from the bypassing component of this analysis, we saw that there are client attributes, specifically age, gender, and ethno-racial associations with bypass, right? And that's something we observed. We noted that there are higher rates of shorter bypass for some of the at-risk groups. We also noted that bypass tends to favor larger facilities and away from smaller facilities. And we also observed some inefficiencies when bypass occurs towards facilities with longer waiting times, as noted for clients of most ethnic groups and most genders. So if we take a step back and just try to make sense of this methodological approach that we're proposing here, we've established the feasibility of the scalable geo-enabling technique of existing large administrative data sets, right? So this is a secondary use of existing data that's out there, that's been utilized for a whole host of analyses. We're just augmenting this spatial component and trying to answer questions that were previously unanswerable, right? What that did is that it opened a whole new domain of covariates that we can add to the classical analyses that we conducted, and that can give us a lot of insights into what affects treatment completion, how do clients behave in terms of choosing facilities. Now, despite the fact that there are limitations in this approach, mainly, for instance, we're simplifying the client address to a single zip code. These approaches do have their biases, right? But we've seen a lot of studies that try to confirm the fact that these biases are manageable and the findings are not way off compared to what we would expect, right? The policy implications here is that we found that shorter drive times to methadone treatment increases the probability of completing that treatment plan, right? This is through using the first set of exercise that we did. The bypass exercise we did told us that the availability of a nearby facility does not necessarily mean that it's going to translate into shorter driving times, right? So these are two sides of that coin, where we'd like to shorten driving time to treatment, but at the same time, building more facilities near where people need care does not necessarily mean that they're not going to bypass around them, right? So there are some supply and demand factors, demand and supply side factors that are associated with where a client receives care relative to where they live. So whenever we're having this expansion discussion, whether we should build more facilities, more programs in different locations, or we should invest in existing facilities such that we're minimizing bypass, because we've established that those that are bypassing tend to favor larger facilities. So there's a tension that we need to investigate even deeper to make sense of which policy makes more sense given the composition of the market that we're trying to cater to. So the future directions has to do with integrating those treatment outcomes into bypass and then understanding the whys of the bypass. I'm sorry, the slide must have been added here. Maybe that's a different version of the slides, but I'm just going to talk about the future directions we can take this into. Integrating outcomes is very important. Completion of treatment, retention of treatment throughout the treatment plan is critical, right? We're trying to understand whether or not bypass, when it happens, how that affects outcomes. That's a very important question to look at. understanding the whys of the bypass, right? So we have evidence of this bypass happening. We can look at what it's associated with, but looking at the causal component of bypass is also something that warrants a lot of deeper investigations. And the policy implication in terms of shortening driving time to maximize the odds of treatment completion, whether or not we'd like to invest in these smaller facilities to minimize bypass, or we'd like to add more facilities such that more patients, more clients have options. So the future directions are very diverse, and it's exciting to see where this research leads, what kind of ideas you might have after hearing all of this. I'd like to wrap this up by thanking the entire team led by Professor Marsh and Dr. Guerrero, Mona, Hortensia, Tenny, and Yinfei, without whom this work could not have been possible. Financial and administrative support for this work came from NIDA, and then a whole host of different organizations that this team came from. I also have my contact info here. If you have any questions, please do not hesitate to reach out. Any ideas, any concerns. This work has been published in some certain journals. We also have a few working papers that we're trying to wrap up over the next few days. So please let me know which components you have concerns, questions about. I think it's a very promising area to explore this marriage between the where and the administrative data that are existent out there.
Thank you, Abdullah. Is it my turn now, Keith?
Yes,
Can you hear me?
yes, the chat feature is now open for anyone's questions, and I see one question in the Q&A already.
Okay. Before we go there, I would just like to thank you, Abdullah, for such a nice presentation of our project's work and the concerns that we're focused on. I'm reminded that some of the findings in this work are very consistent with other findings we have related to organizational capacity in substance use treatment centers. I also appreciate the fact that many of us who are concerned about the services that have an impact on outcome in substance abuse and other social services have realized that transportation is a very significant and understudied area. And your presentation was extremely valuable in helping us understand how this area of study is evolving. Along those lines, I'd like to just ask one kind of fundamental question. As you're developing this technology of looking at using GIS and other computer programs to think about driving time, tell us about what considerations we all made really about what does it mean to study this topic in Los Angeles, where we know driving times are significant. And the other point is, how did we take into account what proportion of our client population actually has access to cars as opposed to other kinds of transportation?
Yeah, so I think the first point we should talk about is the fact that we found that commuting time to treatment was approximately 10 minutes, and it took us a while as a team just to accept that, right? We were not sure. I mean, we expected that driving time was a lot longer, right? And we had to verify that through a lot of validation techniques. We even considered having some members of the team drive physically from certain zip codes just to verify these numbers, right? Because LA County is a very, it's sprawled out, and individuals have to commute very long to get to work. So we thought it would be longer, right? But it seems that coverage is not too bad, as we found, right? In terms of where facilities exist and whether or not individuals have reasonable access to them. So I think that's the first element of this. And then we grappled with the fact that we're looking at driving time when a significant portion might not have access to cars, especially those at-risk populations. And we thought that having driving time is better than not having anything about their commuting experience, right? We use driving time as a proxy for what this commuting journey might look like. We can consider this more or less like a lower bound. That's the best case scenario of driving from point A to point B, whereas if you'd had to take some public transportation, then that would be a different story. The reality that also made this assumption sensible was the fact that a lot of these facilities have programs where they offer transportation services for their clients. And we found that, I think it was, I'm not sure, but more than half of them have these services for clients that need transportation to and from treatment. So that's in a sense a comforting fact, because driving time is now more or less a better measure of how individuals commute. So I think it's new, and what we're finding is something that even we couldn't accept at first, and then we have to make a lot of sense of, and I think we've reached the level where we're confident to say that this is what we think is happening. And then we've broken that down into groups and different at-risk groups, and we looked at bypass and all these behaviors. And this work has been published, and I think the findings there and the policy implications are very well articulated in this paper.
Great, thank you. That's very helpful. Now let us turn to our audience questions. Janet Mason asks, as you indicated, many clients are in methadone treatment for long periods of time, some for years. How are you incorporating this into your completion data if they are compliant with the treatment plan, but continue to be in treatment?
Yeah, so that's a great question. So what we have here is this survey is filled at discharge and at admission, and this is the administrative data is collected at both of those contact points. For individuals that do not comply with treatment, then we have a specific date where we go through all these open applications or open files where clients are no longer complying, and we'd mark them as incomplete. And then for those that span multiple years, we usually look at those that have complete files, right? So those have been discharged during that fiscal year, those would be included, or those who have files that have been closed during that fiscal year, we would mark these as completed treatments or incompleted based on like the criteria that they've established at these facilities. So I hope this answers the question, but for those that are longer, that have been in treatment longer than the study period, I think these might have been overlooked in this analysis. I think it's a great question.
Yes, thank you. It is a great question. I think all of us who study substance abuse treatment grapple with just that question in terms of outcome variables that we use. So next, Alanud Al-Suleiman says, thank you. Can you please elaborate on the medical eligibility component in your research?
So is that, just to make sure I understood this question correctly, so medical eligibility, meaning who has been included in this study?
Maybe we can ask Al-Suleiman to give us a little more detail. Mr. Al-Suleiman?
Jean, I'll have to unmute his microphone.
Oh, okay.
I'll do that right now.
Okay. Oh, here he comes again. Yes.
Hello?
Okay, go ahead.
Hi, yes, thank you. I was just wondering what that actually means in the treatment and how did you measure it? So if you can just give us more information about that specific part, if you don't mind.
Sure. So if we're looking at how these episodes were characterized as methadone treatment, so these, as I've mentioned earlier, these are episodes the data has been filled at admission and at discharge. Usually, medical staff or nurses at those facilities fill in the primary reason that this individual was started on treatment and whether or not they received methadone. So there's a whole data. I'm not an expert on how this data was collected, but there's a handbook that explains all these different covariates and what kind of variables would translate into methadone treatment. So I hope this clarifies, but I think there is a standard definition as to whether or not an episode is marked as a methadone episode, and that's what we're concerned with in this analysis.
Great, thank you. And now Professor Harold Pollack has a question. When there are geographic drive time barriers to methadone, would it make sense to draw more heavily on buprenorphine, which is less logistically complicated for many patients? What are the trade-offs here?
Yeah, I think that's actually one of the policy implications that I've missed. I think that it's great that what we're finding here would probably feed into this debate between methadone and buprenorphine. I think one is less logistically complicated. We still find that methadone is prescribed to these at-risk groups. Maybe even with the expansion of coverage through Medicaid, I should say, across the United States, where this can probably feed into that debate and provide an evidence-based perspective as to whether or not there is a better trade-off in these situations where driving time is longer.
So yeah, if I could jump in here, Harold,
Please.
This question, I mean, we know very strongly from other work we've done that there's a big connection between setting and whether or not you have access to methadone or buprenorphine. And in this sample, generally, well, I think it's changing. The largest MOUD available is methadone, not buprenorphine. This is based on public LA County population. So that has a big influence as well. I'm going to jump now to Peter Friedman's.
Jean,
Yes.
Can I just interrupt real quick because
Sure.
Dr. Guerrero raised his hand. I'd like to unmute his microphone.
Oh, yes, please.
Okay, hold on.
Eric.
Eric?
Hi, everybody. Can you hear me?
Hi, Eric. Yes.
Oh, wonderful. Well, first of all, wonderful presentation. It's just amazing to see how this work is so thoroughly and elegantly presented. Thank you so much, Abdullah. And this is a great question, Harold, because it's really at the core. I think your question kind of points at the core. One of our arguments, we just published this piece in Addictive Behaviors about the bifurcation of the opioid treatment system. And basically the key arguments there is that the system is designed basically to create disparities, right? Where the methadone clinics are primarily located in minority communities and they're highly regulated. So the actual access to it anywhere from the assumption that are going to be closer to those who have problems, are significant. Whereas buprenorphine certainly is a lot less regulated, is available now in all kinds of different options and at very different facilities, anywhere from your primary doctor all the way to some commercial pharmacies. So that in and of itself just creates a different disparity in access to one or the other, but primarily our questions have been about access to MOUDs, including buprenorphine for minority communities. So the patient's choice here, so that is if somebody, a Latino or an African American living in LA County would like to get buprenorphine, certainly that could be even more challenging, and basically coming out of their communities and driving potentially longer to either access a physician that accepts Medicaid. That is one of the key issues. Second, that is already is waivered to provide, an opioid and or access other means. So it is, I think, worth it though for the general population to ask that research question of access to buprenorphine, but that would be a different research question, and one certainly that is critical, especially in a large county where driving is the key way to get to places like in LA County. So I just wanted to kind of have a little bit of more context of how this will look like and why we focused in this particular communities, because that methadone is not only like 75-80% of the opioid or the medication to treat opioids in LA County, but also is one that has been historically there in minority communities and regulated. And even so, we see that African Americans in these communities, they don't go to the first facility. They may select other treatment systems or other treatment facilities for reasons that we cannot avail in the data, but that we assume through some of our interviews that had to do with getting more wraparound services or certainly maybe higher quality. So they may go to larger treatment programs that are a little farther away from where, so they bypass basically more likely because
Eric, thank you so much. You I think represent our project so well, and I'm going to ask you to stay on the line for the next question from Peter Friedman, who asked, do you have markers for OTP quality, public versus private? Could it be that folks who drive longer are driving to a better program? I think that's a great question, and it's central to our concerns on this project. So maybe you want to answer that question as someone who's been focused on organizational capacity in your work.
Yes, thank you, Jean. Yes, indeed, we have a few markers. They're really they're raw, and we have some qualitative data that certainly suggests that clients want to exercise choice, and they may not want methadone. They want to travel to a place that has buprenorphine. What has happened in LA, which has happened in many other large urban settings, is that smaller programs are closing at a higher rate, and or they are merging with larger treatment programs that have more infrastructure to provide services. So that has created, even though the quality in a way we assume may have improved because they are part of a larger system that regulates their service, there has been some issues in terms of really reaching the closest facility. So no longer the moms and pops are in the minority community. They either closed, and then individuals have to travel longer, whether they like it or not. But certainly clients may receive more information about quality more often now. So they are likely to travel and access larger treatment services, again, with higher service capacity, meaning that they provide HIV testing, that they also provide mental health counseling on site. So I think those things are happening more often now because of the mergers and acquisitions and partnerships. And it still is not clear whether that has resulted in larger retention, particularly because Medicaid has been managed as a managed care. So it has been impacting, I think, retention rates with higher supervision on retention on a per day basis. So I think there have been basically all of these factors working together and making it difficult to really understand exactly what the inhibitors of access to care and retention in care. I hope that addressed a little bit the question about quality.
And so we have time for one more question, and we have one more question, and I'm going to let Eric and Abdullah decide who wants to answer this, but Janet Mason is going back to the question about outcome measures, and she says it doesn't answer the question, but because you have a higher percentage of people in the study who did not complete and dropped out, while those who are doing well remain in and may not discharge as completed, so they wouldn't be in the study, could that skew the data? Eric?
Yeah, so I think it's,
Okay, go ahead.
I mean, I think it's worth looking at the proportion of clients that have stayed in treatment for this long, right? And what we've seen is that looking at episodes that span those multiple years tend to represent a very small percentage, and those are for individuals that have completed treatment during the course of the 8 years, right? So we have less reason to think that we're overlooking a large portion of the clients, because during the 8 years, when we look at how long clients have been in care, it seems that very few of them stay in for we're looking at this, maybe anything over 5 years, something we might have overlooked. Eric, if you want to add to that.
Yeah, that's a very good question. Well, basically, we look at treatment episodes. So all the episodes had ended, and they have ended because of a particular reason. There's nine options in whether they completed successfully, whether they completed with successful progress, and then those are 2 or 3 successful, in quotations, outcomes, and then there's 7 options that not successful, but had some progress, and not successful at all, and so forth. But all episodes are completed. Now, the key question here is to also think about whether individuals repeat. We don't have any way to really identify individuals over time, meaning that they come and they're likely to have come again, right? Because most clients have 2 to 3 treatment episodes in a lifespan of 10, 12 years at least. So, so we have also think about, but they report treatment episodes as well. So we account for that, but we're not able to identify the same individual coming to one or different facilities over time. So that can, influence some of our findings. But certainly it's a key question to think about, the how often the clients come in, but the key response is that these are all completed treatment episodes, either successful or unsuccessful.
Thank you, Eric and Abdullah, and thank you all for coming to the lecture and participating in such rich questions. So we have run out of time, but I appreciate all the participation, and please take a look at the roster of Michael Davis lectures coming up, and we'll plan to see you next Tuesday. Thanks so much, everyone. Take good care. Bye.